My name is Dr. Clement Nguka. I'll be continuing with what I did in the previous video. It's a continuation because today I'll be looking at management of heart failure. And I'm looking at the management of heart failure from the perspective of a doctor who is working in primary health care. So I'm not going to look at the complicated stuff that's done by the surgeons and all that. No, I'll be looking at it from a perspective of a clinician. The towering event that we saw yesterday was Disney that the patient presented with because of a failing heart. So the Disney caused by a waterlogged lung. The alveoli or the Essex being filled with water. And that was a problem that caused the Disney. But now, today we're saying, right, that condition developed. But are we going to just look at it? What are we going to do about it? Are we going to help the patient? How are we going to help the patient? The first thing, because there's accumulation of water in the lung, we are going to make means of getting rid of that water. And how are we going to do this? Diuretics. We're going to use diuretics. And which diuretics would we be looking at in particular? It would be nice to look at a loop diuretic, furosemide. Some people like calling it Lasix. And this one is always accompanied by slow K or a potassium sparing diuretic like spironolactone, could be. But I like using it with slow K. Why are you worried about slow K? We don't want potassium to be flushed out because potassium, when it is flushed out, it causes electrical instability of the heart. And that is why we are so conscious that when we use diuretics, we must use diuretics such that we make sure that potassium is preserved, that potassium is there, so that to make sure that the heart, we can't add to the problems of the heart. The heart is already failing. So we can't have now this chemical that is so essential for the stability, the electrical stability of the heart. We can't afford not to have it. So that is why we're using furosemide together with Lasix. Together with slow K. And that's okay if we do that. We want to make sure that the kidney helps us to excrete this water, to make sure that we don't have a surplus of water. When the water has been excreted, then there's going to be blood that is circulating, but now it will be in normal amounts. It will not be such that there will now be a relief of this dizzy that we were trying to we saw as a problem. We now will have an amount of blood that is okay for the heart to handle. So that's one thing. That's one thing that we have done. But that's not all that the heart did, or perhaps what the patient experienced. The patient experienced, because of the insufficiency. When a heart is failing, the delivery of blood to all the parts of the body is very much insufficient. And it is insufficient even to the myocardium. And when it is insufficient to the myocardium, something else happens. There's a marked demand of oxygen by the myocardium, by the heart muscle. A marked demand. And this is in excess. It's unmet by the supply of blood. So the supply of blood to the myocardium is not enough. And because it is not enough, this generates pain that is actually from the heart. And this pain from the heart is given a special name. It's called angina pectoris. When there's angina pectoris, if it happens once in 6 months, we call it a stable angina. When it happens again and again, it happened in the morning, now it's happening now, it happens yesterday, it happens again. The frequency of the angina is increased. When it is increased, this angina is no longer a stable angina, but it's an unstable angina. And this is a threat, because now, when it's like this, it's going towards a myocardial infarction, which is a condition that I can't handle in the primary healthcare centers. I can't handle this. This must be a hospitalized patient. The patient has got to go to hospital, and in particular must be seen by the physicians and the cardiologists, because we're dealing now with because a myocardial infarction is exactly what happened. It's one that damages the heart and giving rise to more heart failure, because damages the heart. It depends now how severe is the damage. Damages the heart. But then how do we address then this problem? How do you address the pain? How do you address the angina? We use quite a number. This is in a primary healthcare setup. The surgeons, the cardiac surgeons or the cardiologists would look at the removal of whatever obstruction that caused the myocardial infarction. They would look at that. But that's not where I am. I am in a clinic setup. I can't think of. So they are worried about the supply. They say they are worried about this. There are two things that you should have in mind. You're worried about the demand. And you worried when you know that the demand is increased. The demand of oxygen is high. And the supply is not enough. Now, the surgeons can deal with the supply, but I can't deal with the supply. I can only deal with the demand. How do I deal with the demand? I reduce the work of the heart so that there should be less oxygen needed by the heart. That's good. I reduce. But how do I do that? How do I do that? How do I reduce the... I can use drugs like GTN. You know GTN? Glyceryl trinitrate. Put it right under the tongue. Under the tongue, oh, there are quite a number of blood vessels which are very good. Those blood vessels, they absorb this GTI, the GTN, that is glyceryl trinitrate. They absorb it. You know, you mustn't work in casualty. There you're going to see a lot of this. In casualty, you will see patients who come in crying. They are in pain. They are in pain, chest pain, this chest pain, chest pain. And then you put in your GTI, your GTN. Put it under the tongue. The patient says, oh, thank you very much, doctor. Thank you very much. Badangi doctor. You know, in South Africa, we speak Afrikaans. Badangi doctor, kan ek eens toe gaan? You know, that's what they say. That's what they say. They get an immediate relief because the GTN is a vasodilator. It dilates the blood vessels there so that the demand, you must remember, when the blood vessels are constricted, that causes a high demand for oxygen because it's the constriction. So the heart, the work of the heart is too much because they've got to beat that constriction. They've got to push the blood through that constriction, a constricted blood vessel. So now, what you've done by your GTN, you have vasodilated. You have dilated those blood vessels. In other words, you are reducing the work of the heart. So now the demand goes down. This is something good to understand. So the demand goes right down. And it's an immediate relief to the patient. And the patient says, thank you, doctor. Can I go home? Can I go home, doctor? I'm fine now. I'm fine. But now you left with a job of trying to understand how severe was this attack on the heart. How severe? So you can't just respond like that and simply discharge the patient and all that. You need to find out. There are quite a number of things that you have to do and to find out what could have gone wrong. How far did it go? Did it reach a myocardial infarction stage? What was the problem? So the main thing is, from my side, I address the problem of demand. And how do I address the problem of the demand? Reduce the workload on the heart. Reduce the workload. And if you reduce the workload, it means you are reducing the amount of oxygen that is needed by the heart, which is good for the patient. Good for the patient because the patient gets relieved. And is that all? Is that the only? Oh, you can get nitrates. Oh, this is already a nitrate, but you can get other nitrates do this, you can get a beta blockers. And when you get to beta blockers, you're doing the same thing. You're reducing the workload. You're reducing the workload. But when you get to beta blockers, if you are brave enough to use beta blockers, I must say I am not brave enough to use those beta blockers for one reason. Beta blocker has got a negative inotropic effect. What's that? A negative inotropic effect, it means it reduces the ability of the heart to contract, or the potential of the heart to contract. In other words, to beat. But the heart is already struggling with that because this is the heart failure patient. So to use a beta blocker, which has got a negative inotropic effect, it's not something that I would hand over the patient to the great guys, the big guys, to do that. I wouldn't do it at a primary health care level. Because what if the patient goes into cardiac decompensation? The patient just goes right out, cardiac decompensation. When now the heart failure goes worse, what do you do in a primary health care center? In my clinic, I want stability there. I don't want all this. So I wouldn't be confident enough to use my beta blocker at it. It doesn't matter. Also, there are other problems. I don't know if the patient in front of me, he has got a bronchospastic disease like asthma. I don't know that. Remember, I'm first line, by the way. I'm the patient, I'm the first healthcare worker that the patient meets in hospital. I'm first line. So I have to hand over the patient to the specialists. So as first line, I don't know whether I'm meeting the patient for the first time. I don't know whether the patient has got a bronchospastic condition like asthma. In which case, I would be worried to use my beta blocker, because beta blockers will make the wheezing worse, will make the patient to be out of breath. The patient is out of breath already from the dizziness that the patient got from a failing heart. So now, here am I, this patient in front of me, maybe this patient has got a bronchospastic condition, has got asthma. And so I'm worried about, the receptors in the periphery. I'm thinking about the lung. The receptors there are beta 2 receptors there. And once I use a beta blocker, bronchoconstriction. The patient can't breathe at all. Oh, that's the worst thing that can happen. Of course, maybe I'll say when I'm trying to defend myself, no, I was targeting the beta 1 receptors which are in the heart. But then this is a beta 1, this is a beta 2, these are beta receptors. The beta receptors. And I said, no. But I used a cardio selective drug. That's what I used. A cardio-selective drug. Oh, you used a cardio-selective drug. But those are dose dependent. So I don't know the dosage that you used. Even if when you increase the dosage, they lose their cardio-selectivity. So it's just not very much safe to use. Of course, it would help. It would bring down the heart rate. It would bring down, which will help. It would bring down the blood pressure, the vasoconstriction and all that. It would do well. But what do I do? This is a beta blocker. It has got a negative inotropic effect. I can't forget that. I can't overlook it when dealing with this patient, because in the first place I don't know the his. Well, even if I were to know the history of the patient, once I find that the patient has got a bronchospastic condition like chronic obstructive pulmonary disease, like asthma, you never really know. So rather act safe than to be sorry. Act safe. Know that a beta blocker would have, would have a negative inotropic effect. That's important to understand. No, but I will use calcium channel blockers. Calcium channel blockers. Which ones are you talking about? Because there are two types. There are dihydropyridines and there are non-dihydropyridines. Which one would you use? Because the non-dihydropyridines, like verapamil, like diltiazem or cadmium, these have a negative inotropic effect as well. So I wouldn't use the non-dihydro. So I would end up with the dihydropyrimidines. Which ones are you talking about? I'm talking about nifedipine. I'm talking about amlodipine. I'm going to use those orally, right? Of course, even the others, I would use verapamil. Oh, my teacher loves this non-dihydropyrimidine that is verapamil. Verapamil. This is always says, oh, verapamil works, man. Verapamil works. Right. So that's what I would use to make sure that I would use amlodipine. Amlodipine is safer for me. I don't have a problem with amlodipine. I would use it to do the same thing, bring down it reduces the work of the heart. The work of the heart. This is something that I would make sure that at all costs I use. I would address, first of all, the dyspnea of the patient that developed because of a waterlogged lung. How would I do this? I will not forget my diuretic. And what diuretic of choice would I take in this case? Well, with me, because I don't know anything about this patient. I don't know whether the patient has got some renal problems, in which case I can't use my, diuretic of choice, Redac. No, I wouldn't. I would use a loop diuretic. My loop diuretic would be my furosemide, and I would use it together with slow K to try and preserve my potassium, because potassium is responsible for electrical stability of the heart. Right. So that's actually good. It works. The heart works well with potassium there. If I were to use a potassium sparing diuretic, I wouldn't use it alone, because I don't want to precipitate a hyperkalemia which would cause a cardiac arrest. No, I wouldn't do that. That is why I want to use my furosemide together with together with slow K. Then I address the chest pain thing. Chest pain, the angina pectoris. Angina pectoris. How do I do this? I reduce the workload of the heart. Reduce the workload of the heart. How do I do that? Well, I'm thinking of beta blockers, but I would hand that over to my specialists to do that. Because there's yet another thing with the beta blocker. If you're using a beta blocker, you are worried about leaving the alpha receptors unmonitored. If you leave the alpha receptors unmonitored, there's adrenaline that's going to work on those. There's no adrenaline that's going to work on those. And that's vasoconstriction. What is that? Vasoconstriction causing what? causing workload of the heart to be high. You don't want that. So here's another disadvantage. So if you use a beta blocker without an alpha blocker that we use is phenoxybenzamide, and it controls the alpha, so that to make sure, and when we use it with a beta blocker, so that there should be no reflex tachycardia. This is. Thank you very much. Thank you very much. I would like to thank you for 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 listening to me, and then as long as one understands that the management of this condition would be to try and make sure that the workload of the heart is reduced. And what will I be thinking about? I'll be thinking about my beta blocker, though I'm not going to use it because I'm not confident enough to use that. I'll hand it over to my specialists to do that, because of the reasons that I tabulated. Beta blockers being problematic with bronchospastic patients, and then the cardioselectivity not being, increasing with the cardioselectivity. Actually, the cardioselectivity, decreases with at the increase of the dosage of a beta blocker. And I would never use it without my phenoxybenzamide, which addresses the alpha constriction, which will be caused by adrenaline and noradrenaline. Thank you very much.